Fantastic. Well, thank you so much, Kyle and Andrea, for the introduction. And thank you so much to everybody for attending tonight. It's a great a pleasure to have the chance to at least speak with you virtually over the phone, and I can imagine that you're all there listening in or wherever you may be. Let me just make sure that the pointer is working. I'm going to be speaking largely about specifically HIV pre-exposure prophylaxis, or PrEP, even though the title of the session overall was, HIV prevention in general. Certainly, this is kind of our latest and greatest tool, I think we could say, in terms of HIV prevention these days, and I think it's where a lot of the excitement and greatest interest lies, although I'm very happy to also take questions, comments, and have some discussion at the end around other HIV prevention modalities as well. So in this next slide, I'm just showing you a picture that I took one day as I was leaving St. Michael's Hospital. I was walking through the Eaton Center on the way to get some exercise at the gym, and I saw this poster. It's a poster that was actually put up, as you can see here, by a makeup company, by Clinique, saying PrEP, PEP, and Party. And I couldn't resist taking a photograph to include in some of these kind of presentations that I do about pre and post-exposure prophylaxis, because I think, there is a little bit of a sense out there sometimes in some circles that these are really party drugs. Certainly they're not makeup products, but nevertheless, I hope to show you in some of what we'll talk about together in the next 45 minutes or so that, we really can and should be thinking about them as, tools that we can use systematically. I think it's fair to say that some people truly might use them really in the context of quote-unquote partying, and that's not something that we should, as clinicians, judge or devalue. It's certain people's realities. But recognize that there's a diversity of reasons that people use these tools. There's certainly some really valuable ways that we can harness them from a public health and clinical perspective. And I hope to provide some insights to you today on how you can be involved in that. So the learning objectives that I propose for our time together are listed here. So we'll start by just briefly defining and describing some HIV prevention methods and really focusing in on PrEP itself. Second, I hope that through this session and other resources, you'll be able to increase your comfort at identifying patients within your clinical practices who may be at higher risk of acquiring HIV and therefore be a good candidate for PrEP initiation. And then finally, we'll spend a chunk of time really talking about an evidence-based approach to prescribing PrEP. And for this, I'll really rely on these clinical guidelines that our team put together a couple years ago that are published in the Canadian Medical Association Journal, or CMAJ, and are freely downloadable off the web. So if we start by just defining and describing HIV prevention methods like PrEP, sorry, we'll do that in just a moment. I meant to remember that I wanted to preface this by saying, why do we need more prevention tools? And I think this sort of data slide really tells the whole story. This is looking at HIV diagnoses in the province of Ontario over the last more or less decade or so. It's the most recent data available from OEZ on their website, broken down according to male and female individuals. And you can see that the main message is that although there have been some improvements in the last several years compared to the earlier part of this graph, certainly we're not seeing a decrease. And we really are in an age where we've had the tools to see this number go down over the last, over most of the time period that's shown in this graph. Certainly the first trial that showed that PrEP worked was published right around here. So it really speaks to the need urgently for new HIV prevention tools in our setting, mirroring what we see in many other settings around the world. The other thing I wanted to show you in terms of breakdown is, of course, that since the dawn of the epidemic, and certainly in the most recent time period as well, the vast majority of infections have occurred within people who identify as gay, bisexual, or other men who have sex with men. We sometimes use the acronym GBMSM. I should say the majority of infections occur in this population such that the vast majority of prevalent cases are in individuals went from this category. So it really has logically been a focus of efforts to roll out PrEP more aggressively in many industrialized settings. So this is a slide from the Public Health Agency of Canada, again showing some of the breakdown of HIV infections in the whole country, and again emphasizing that when you compare the number of infections that occur in various key populations in the country and compare that to what we see in the rest of the population, you see that it really grossly disproportionately impacts certain priority populations, certain historically marginalized populations. And once again, we see with some of the older data for HIRI-MSM that the estimate was about 71 times greater incidence of infections compared to the general population. You see that reflected also, again, in the prevalence information. So once again, I think when you speak to the general public and talk about what the status is of the HIV pandemic in today's world, people typically think of settings in sub-Saharan Africa where we see extremely high adult seroprevalence numbers in the high teens or even low percentages. These are the highest rates that you see in the world. But right here in downtown Toronto, when you look specifically at, again, HIRI-MSM, you see prevalences that are quite comparable. And so in many ways, we have an epidemic right here on our doorstep, in our midst, that rivals some of the most dramatic epidemics in the world. So really speaks to the need for new interventions. So what might some of those be? Well, certainly PrEP may be one important one of those. We can define PrEP as the use of very specific, not any, but specific anti-HIV medications in individuals who find themselves at high and ongoing risk of HIV infection. And of course, it's pre-exposure, so it begins before and it continues after a potential exposure to HIV, and the whole purpose is to reduce the risk of acquiring HIV from that potential exposure. Now, I suspect many in this audience know that PrEP is not the same thing as post-exposure prophylaxis, or PEP. PEP, in contrast, although it sounds similar, is something that's been around for a lot longer. So we've known for a long time that you can use anti-HIV medications, and it's much more flexible which ones you can use, immediately after a potential exposure to HIV in order to decrease the risk of acquiring infection. It's something that we historically used all the time in the kind of healthcare worker setting who might have injured themselves with a phlebotomy needle, for example, something like that, and seeks PEP. But in the last couple of decades, we've really been rolling this out more frequently in the context of non-occupational exposures, so sexual exposures, injection drug use exposures, and certainly is known to be very effective. However, we're going to really focus in on PrEP today because, again, it's newer. It probably has greater potential population impact, as you'll all agree. And it really utilizes this pill at the bottom left, which is why that image is there. We've got this mosquito in a no mosquitoes symbol here for a funny reason. If everyone was in front of me, I would ask if anyone could figure it out. But it's really because, PrEP, although we think of it as a brand new and in some ways initially controversial and paradigm shifting way, in fact, there's precedent for the use of pre-exposure prophylaxis in other infectious diseases, and use of anti-malarial drugs is a classic example of this. No one would bat an eyelash at our recommending the use of an anti-malarial to someone who's going to spend some time in an area that's endemic for that infection. That's pre-exposure prophylaxis for malaria, and in much the same way, we're using the drug we'll talk about in a few moments in that way for HIV prevention here. And it's very also similar to the birth control pill for prevention of pregnancy, which draws a lot of nice parallels because of the common transmission route, if you will, of sexual activity. So I also thought it would be helpful to just spend a moment looking at the biology of HIV transmission, just to briefly remind us of why it even makes sense that PrEP works in the first place. For some people, this is a little bit surprising. So this is a diagram taken from a nice review article published in the New England Journal of Medicine many years ago, and it's showing us a graphic of a mucosal surface of the body. This could be the lining of the vagina, it could be the lining of the rectum, whatever, and you've got a bunch of viruses that are landing here, maybe in semen, maybe in blood, maybe in cervical secretions, rectal secretions, whatever, and in order for an HIV transmission event to occur, these viruses, or cells containing those viruses, need to first breach this mucosal barrier. And if they do that somehow, they're going to first encounter cells that are called dendritic cells. These are cells of our immune systems whose job it is to sample the environment and protect the host, the person, from invaders. If they pick something up, they're going to pass it on to another cell of the immune system, in this case a CD4 positive lymphocyte, which kind of gets activated and triggered to turn on the immune system and try to activate our defenses to try to fight this thing off, whatever it may be. Part of that involves traveling to local regional lymph nodes so that it can communicate with even more cells of the immune system, and from there it gets disseminated through the bloodstream to other organs in order to fight off whatever this invader is. And what I'll now add on is some arrows to point out that we've learned through some animal models that if you artificially infect a monkey, for example, a macaque, with SIV, the equivalent of HIV for that animal, you can see that the virus is already present in these dendritic cells by about a few hours actually after the transmission event occurred, and it arrives at these regional draining lymph nodes within about 2 days or so, and then it disseminates to the bloodstream by about 3 days. And it's for that reason that in the setting of post-exposure prophylaxis, we always say that we want to intervene as soon as possible and no later than 72 hours after the exposure. And it's really the same thinking that we've used in the context of PrEP to say, you know, what we really need is we want drug to already be present here in this window of time when it's possible to abort an infection even though the virus may have entered the new host's body. So the goal of PrEP, as I've said here, is to accumulate protective levels of an anti-HIV drug in the relevant tissue before the exposure occurs to prevent infection. This also raises a really important pharmacologic principle, which is that obviously this doesn't happen immediately once you take a drug. And it's thought that, for example, in gay, bi, and other men of sex with men, it takes a little less than a week to accumulate enough protective levels of this drug in the rectal tissue, which would be the most relevant tissue for sexual transmission in the population, in order to kind of have that protective effect. So there's a really compelling evidence base that daily PrEP works in this population. I've listed some of the clinical trials and large cohort studies that kind of sealed the deal for us on this slide. There's not enough room to go through all of the trials, and I'm also not going to take the time to kind of walk through all of these results right now, but IPREX was the first trial that definitively showed us this. That trial was published, as I alluded to earlier, way back in 2010, so almost 10 years ago now that we've known that PrEP works. And just to emphasize how well it works, you know, in that first clinical trial, we saw that many people weren't taking their drug, but in those who were taking their drug, they had detectable drug levels. The efficacy in that first trial was already very high, 92%. In this larger cohort study called the IPREX open label extension, it was seen that when people were able to adhere with their medications regularly, the point estimate was that it actually prevented virtually 100% of infection. So it decreases risk by virtually 100%. There's a confidence interval around that, of course, but it's this compelling data that allows us to tell patients and reassure patients when they ask us how well this works that, you know, in this population, if you're taking your drug regularly, it virtually never fails. Now, I say virtually never, I never say never, because we know that it very, very rarely does fail, but we don't like to emphasize that because it's not necessary to emphasize that. It really does work extremely well in the overwhelming majority of cases when people take it as advised. Also worth pointing out, of course, that PrEP works in other populations as well. We're not going to spend as much time talking about, for example, people who inject drugs who may find themselves at risk for HIV, heterosexual men and women who may find themselves at risk for HIV. Certainly, though, clinical trials have compellingly showed us that it does work. Here is a column showing the estimated overall reduction in HIV seen in these study populations. I won't dissect these data in great detail, but I will just emphasize that although some of these numbers may not look terribly impressive to you, when you look at them, you know, 50% reduction, 60, even 75% reduction, remember that these were all the initial estimates from these clinical trials in which we know that unfortunately many of the study participants were just not able to take the study drug regularly. So we know that adherence to the study product was actually fairly poor in many of the clinical trials. And that point is illustrated really nicely in this diagram that I like to show as well, where I want to emphasize the message that the key determinant of PrEP efficacy is medication adherence. So the better you take your drug, like any medication, the more it's going to work. So the way that this graphic tries to illustrate that is by showing a whole bunch of studies. Each one of these dots is a different PrEP trial. On the x-axis here is the percentage of participants samples from that clinical trial that had detectable levels of the drug. So more adherence is going to be on the right of this graphic. And then on the y-axis here is the effectiveness estimate from that clinical trial. And you can see that there's a nice relationship between the two things. So clinically, what this tells us is that patient counseling and adherence support is really critical, and that's something that we as clinicians can intervene on. The last thing I'll say is that, or one of the last things I'll say is that about how well this works is that there's now actually two different products or pills that can be used as PrEP. One of them, the initial, Truvada, is the trade name for tenofovir disoproxil fumarate with emtricitabine. It's an awful lot easier to say Truvada. Is also now available as generics. So I often typically will now actually refer to TDF-FTC as the drug that we typically think of as using as PrEP. So this is what they look like. And it's worth pointing out that there's this other newer product as well. It's another version of tenofovir, but called tenofovir alafenamide. That's being paired with emtricitabine, so TAF-FTC. This is the trade name, Descovy. And this is what the pills look like. There's two dosages because there's some drug interactions with HIV drugs that become relevant, but it would typically be the blue tablet that might be considered for PrEP. Both of these products are approved for HIV treatment and have been studied as daily PrEP. TDF-FTC is the one that's been studied most extensively. There's only a single trial looking at Descovy as PrEP that showed that it worked in GBMSM. On the left-hand side, you can see, though, that TDF-FTC has also got this unique situation where it's been proven to work as on-demand or intermittent PrEP. That's not the case for Descovy. Also worth pointing out that the on-demand trial for TDF-FTC was done, again, only in the population of GBMSM. So TDF-FTC is widely used and is approved for PrEP. TAF-FTC is going to start emerging for use as PrEP. We could talk about that if you're interested at the end. Importantly, though, recognize that it does not have a Health Canada indication for that right now. So any such use as PrEP would be off-label. And the major clinical trial that showed that it worked has not yet even been published. It's only been presented in conference form earlier this year. So the bottom line with PrEP, it worked extremely well at decreasing the risk of HIV acquisition in people who are at high risk. We say more than 90% overall in GBMSM. Again, I say virtually 100%. And efficacy decreases significantly in folks who are not adhering. So that's why we recommend simple things like a pill box, some sort of daily reminder, an alarm on your smartphone to help people remember to take it consistently. And it's really part of a combination approach to HIV prevention. A common critique was, well, you're abandoning condoms. No, we're not abandoning condoms. We're using this as an adjunct. People typically these days have already decided how they're going to be using condoms, in what situations, with which partners. This is another useful tool to help us finally get that HIV incidence curve to start to decrease, because we've been relying on those other tools in isolation for an awfully long time without seeing results. So this slide is just to make that same point once again, that we really want to use all these tools: behavior change, treatment of HIV, STI management, structural interventions like social justice and human rights, alongside something like PrEP, which is a biomedical strategy, in order to have a highly active HIV prevention paradigm analogous to our highly active antiretroviral therapy for established HIV infection. So let me move on from that first introductory section about what PrEP is to talking a little bit about how one might go about identifying people as being a good candidate for PrEP because of their elevated risk for acquiring HIV infection. And where we're really going to turn for this is the clinical guidelines that I alluded to earlier that are published in towards the end of November in 2017 in the Canadian Medical Association Journal. It was timed to come out together with World AIDS Day that year. And we really went through a rigorous approach to developing those guidelines such that they truly are, I think, evidence-based. We used a system that's called the GRADE system for developing guidelines, which recommends that any recommendation within the guideline be classified according to a relatively simple scheme. The strength of the recommendation is either level 1 if we recommend it, or it's level 2 if it's something to be considered, depending on the clinical situation. Sorry for this getting cut off here, but this bullet point refers to the quality of the evidence, which is given a letter grade from A to B to C to D, from high to very low, and you can see the examples of quality of study designs that would lead to these quality designations listed here in the table that I won't read through. So with that in mind, this is what the guideline cover looks like. Sorry, this is actually the title for the guideline synopsis, which is the main article that you'll find if you go to the website. I do want to point out that this document it's about 10 pages or so, and it's just a synopsis, which just gives you the high-level points, the main recommendations, a couple key tables to refer to. The full synthesis of all the data and the rationale for the various recommendations is actually in a much more detailed document that's labeled as Appendix 1 on the website and within the document, and you can also download that for free if you're looking for the nitty-gritty on what justifies one of the recommendations or suggestions within the document. So I'll focus in this section just on what the indications were that we landed on, first for gay, bi, and other men who have sex with men within the guideline. We recommended PrEP within the guideline using a grade 1A recommendation, so a strong recommendation with high quality evidence, as well as transgender women, slightly poorer quality of evidence, but still a strong recommendation, if they report condomless anal sex. So we operationalize that as being within the last 6 months. You might consider that that's relevant also if it's their intent to do this, or if it's very recent, or just beyond 6 months. And if they have one of the following other more objective, if you will, risk factors for acquiring HIV. So other bacterial STIs are a big one. Infectious syphilis or a rectal bacterial STI, such as gonorrhea, chlamydia, maybe LGB, particularly if that was diagnosed relatively recently, is definitely an indication for PrEP. Recurrent use of PEP, so non-occupational PEP, PEP in the context of a sexual exposure would be another one. A small number of people might be in an ongoing sexual relationship with an HIV-positive partner who has a substantial risk, we said, of transmissible HIV. Essentially, that means they're not achieving virologic suppression on their HIV treatment, or maybe they're not on HIV treatment. And then the last one is if they score highly on this risk score that I'll show you in just a moment. In all these situations, we would say this person should certainly be recommended or advised to consider PrEP for HIV prevention. We make this other important point, which is a pertinent negative in clinical thinking. You know, PrEP is not recommended in the context of a stable, closed relationship with a single partner if there's no, or if that person has no or negligible risk of having transmissible HIV. What does that really mean? That really refers to the situation where someone is living with HIV, but they have an undetectable viral load on treatment. This is really emerging from the U equals U movement, which is itself based on extremely rigorous data that tells us that an undetectable viral load is itself a definitive way to prevent HIV. It is not possible to transmit HIV in the context of an undetectable viral load, which is amazing news. It's not just really, really low. It's not possible. We say it does not get, the risk is 0. And as a result of that, we say that PrEP is not recommended. So what's that all based on? Well, here's some local Canadian data, mostly out of Vancouver and British Columbia from our colleagues who work there, showing what the estimated incidence of HIV is in GB-MSM in that setting, according to the presence of different risk factors. So these are things like syphilis, rectal gonorrhea, which I referred to earlier, using PEP more than once. You can see that these incidences are 3, 4, 5, 7 per 100 person years. And if you just put that in global context, again, those sorts of incidence rates are comparable to the worst or highest rates that you see around the world in countries that are extremely hard hit by the HIV pandemic, such as in different countries within Southern Africa. So we really have compelling evidence that these are very clear situations in which we should be actively, not passively, but actively recommending PrEP to people because we know it can prevent infections. That other indication that I referred to was this thing called the HIRI-MSM risk index. It stands for the HIV incidence risk indicator or something like that. I apologize, I can't remember the exact acronym right now. That was published in JADES several years ago. It was developed by the CDC in the United States. And essentially, it's a 7-item index for quantifying HIV risk. And it's based on some older U.S. cohort studies. The higher your score, the higher your risk. And on the next slide, you'll see what those questions are. I'm not going to read through them, but you'll see that one of them is pretty easy. It's your age. And then the others look at numbers of partners. They look at some recreational drug use, poppers and meth, or amphetamines in general. And you can fairly rapidly score someone and figure out what their risk is. Again, back to our guideline, we recommended that the score is greater than 10 in the context of condomless anal sex, which itself gets you a lot of points. PrEP is appropriate to recommend to someone. So hopefully this will give you some tools that you can practically apply to figure out who is, immediately jumping out as a potentially good candidate for HIV PrEP because of their elevated risk. For other populations, there's unfortunately not as compelling clinical evidence to tell us what very specific risk factors have high sensitivity and specificity for a future HIV infection. That's why we were left with very loose language around, someone who's got partners, either a sexual partner or an injection drug use partner who's got a substantial risk of transmissible HIV. Sure, those would be settings in which we know it works really well and it would be very reasonable to consider PrEP usage. But unfortunately, the existing data don't give us more specific and operationalizable, I should say, indications. And it's really, of course, like any guideline, left to the individual clinicians to take the unique circumstances of the patient in front of them into consideration to figure out when to recommend PrEP. So a couple last points I wanted to raise before we talk about how to actually do this, and then we'll open to some questions or comments. Historically, PrEP has unfortunately faced a lot of controversy, some reactions that people have historically had, some discomfort that they've had. And I wanted to just show you a few examples of them because they commonly come up in this conversation about why we're recommending PrEP or who we're recommending it to. A very common concern is, well, that's fine that it works, but why can't the person just use condoms? And you might understand why people ask that question or have that comment. Condoms are a heck of a lot cheaper, and we know they work extremely well. The problem is, though, that although we, of course, want to recommend them, we still do encourage people to use them as much as possible. The reality is that there are lots of reasons that people are already not using them. And in fact, once again, that's part of the reason we've failed to see a decline in HIV incidence, despite all these amazing tools we've had for decades. Okay, and so, we've listed here, people are unable or unwilling to use them for very understandable reasons: discomfort, pressure from their partner, power dynamics such that they're unable to negotiate condom use with their sexual partner, sometimes lapse in judgment, a frank desire for more sexual pleasure, etc. So it's really just looking at the data. The data are telling us that, yes, this is important, and yes, of course, we recommend their use, but it's just not working. We need more. I don't want my patient taking an unnecessary medication forever. This is a healthy person. Why on earth are you putting pharmaceuticals into this person? Well, PrEP is not a lifelong prescription. It really should be tailored to people's periods of risk, their seasons of risk, and we really prescribe it at 3-month intervals with no repeats or refills, as we'll get to in a moment, in order to ensure that people remain HIV negative, and those frequent follow-up visits provide frequent opportunities to constantly reassess the indication. Finally, what about the cost? That's a very pragmatic and realistic concern, certainly in the fiscal climate that we all are dealing with today. And I think the best response to that is that, PrEP is very clearly shown, lots of rigorously done cost-effectiveness analyses to be very cost-effective. That's true when we target it to people who are at high risk. And in addition, in the last couple of years, the availability of generic TDF-FTC in Canada has dramatically reduced medication costs. It's reduced it 4-fold, in fact. And as a result, you're seeing public insurance plans across Canada and elsewhere increasingly cover PrEP as a result. Here in Ontario, as we'll allude to, it is covered under ODB, and we'll talk a little bit more about that in a moment. I want to move on now to talking about how you actually might go about doing this. And as nurse practitioners, of course, you're all equipped to do this. You could start doing it tomorrow, conceivably, if you're comfortable with this information, if you're not already doing that. at this time. So this is just a quick overview slide to kind of give you a sense of the approach that we recommend. The columns here represent visits to the clinic, and you'll see that we recommend a screening visit where you do a whole bunch of assessments, followed by a baseline visit where you actually start PrEP on person in light of the screening results. We recommend a check-in about a month later. Admittedly, maybe this is optional. Not everyone is absolutely finding this necessary. But then we do recommend that follow-up occur on a quarterly basis, so Q3 months, to do a few quick check-ins, including the monitoring for incident HIV, STIs, toxicities, as well as a reassessment of the need for PrEP and counseling on adherence and other risk reduction strategies. Once a year, at those quarterly visits, we add on a couple things as listed in the slide here. So if you look at the actual things we're recommending, really it's pretty basic. It's HIV serology, viral hepatitis, STI screening, a little bit of renal function screening, and then the counseling pieces. So it's pretty straightforward and can really be done fairly rapidly, actually, allowing for high volume when people become comfortable and when patients themselves have kind of settled into a groove. One of the key pieces at each of those encounters is confirming HIV negativity. And this is really critical because we know that, well, PrEP is obviously only effective as an HIV prevention tool if the person is already HIV negative. If the person has HIV unknowingly and is continuing to take PrEP, a major concern is that it could potentially lead to HIV drug resistance emerging. That's because PrEP involves, as we said, 2 HIV medications, TDF and FTC, perhaps TAF and FTC, whereas HIV treatment classically involves 3 drugs. That might include, for example, those other 2, but in conjunction with a 3rd drug. And as a result, someone who acquires HIV without realizing it, keeps on taking their TDF FTC, is actually no longer taking PrEP, they're taking inadequate treatment, and that will lead to resistance predictably. So that's why it's so important. The way we recommend doing this is, of course, ordering an HIV test in advance of each visit and ensuring that it's non-reactive at the time that you provide the prescription. Importantly, we recommend no pre-marked refills on PrEP prescriptions, and that's why over here you can see that on the sample prescription, we always check that box, do not refill. Okay, it's a built-in way to require the individual to repeat their testing, come back in order to continue on the medication. It's also important to assess clinically for recent HIV seroconversion symptoms because we all know that the HIV test itself has a little bit of a window period around it. And I'll talk a little bit more about that on this next slide over here. So this is a little bit more complicated. Perhaps this is familiar to many of you. The graphic up here is showing you the sequence of events that occurs when someone's acquiring HIV infection. Okay, so this is measured in weeks after acquiring infection. The blue line represents the very first thing that happens, which is that you can detect the virus in the blood if you were to do an RNA test, a viral load test that directly looks for the virus. This is not a test that we use diagnostically, though. The test that we classically use for HIV diagnosis is the 4th generation EIA that combines testing for HIV antibodies as well as this thing here called P24 antigen. And you can see that those take a couple of weeks to evolve. Okay, this one in particular, the antibody, because it takes time for the body to mount an immune response against this new virus that's just invaded. It takes, on average, about 3 weeks for these tests to become positive. And that period of time there is what we call the window period. So that means that you could potentially get a falsely negative result in someone who truly has infection if you're testing them within those first few weeks of infection. Now, you may remember that in the older days, we used to say that the window period for HIV tests was 3 months. And that's because, it's not because the average time was that long, it was because the kind of the last person, if you will, and the longest potential time that it might take for the antibodies to form was as late as 3 months. But that was with what we call 3rd generation tests, okay, up to about 3 months, as you can see on this graphic here. These days in Canada, we're using a 4th generation test. That's what you automatically get if you ask for an HIV test. And you can see that that's a little bit shorter in terms of the potential maximum window period. But once again, the average window period is actually shorter. It's about 2 to 3 weeks. So you can rest assured that in most cases that's fairly accurate. But in case someone had a high-risk exposure just 2 or 3 weeks ago, you need to be thinking about what else they might be presenting with. They might be presenting with symptoms. Not all the time, but sometimes. And this table shows you some of the more commonly reported symptoms in people who are having an HIV seroconversion illness. I'm not going to talk through all of these. They're familiar to most of you probably. But I will just point out that most of these symptoms are things that you would probably put into the category of, generalized flu-like illness, fever, weight loss, etc. But please remember that some of them are what I like to call falsely localizing symptoms. So pharyngitis. You might imagine, a young person coming into the office with fever and a sore throat. You're gonna try to rule out strep throat. And unless you realize that that's one of the presenting symptoms sometimes of HIV seroconversion, it's easy to forget that that person requires an HIV test. Similarly, if you think about diarrhea, similarly if you think about headache, which might be a manifestation of an aseptic meningitis. So just remember that in addition to the generalized kind of not feeling well symptoms you're always thinking about with an HIV seroconversion illness, always also screen for these false localizing signs. And if you are so, I don't know whether to call it lucky or unlucky, if you are astute enough to pick up one of these symptoms in the setting of a negative test, think twice and maybe retest to be certain that the person isn't acquiring HIV before you provide that prescription or provide that refill. So in the very, very unlikely event of an HIV positive result, a few points to mention. Hopefully this will not happen to you if you're involved in prescribing PrEP, but it is a common question that we get asked, so I wanted to include some content on it. The first thing to remember, the most common reason for, unfortunately, failing PrEP, if you will, or acquiring HIV despite PrEP is related to adherence. So doing a careful adherence assessment to assess the probability of a true positive may be helpful. Recognize what you're looking for. A confirmed positive involves that reactive screening test plus a confirmatory test. Sometimes if you're just getting someone who is unfortunately seroconverting, it's not going to be that definitive. And so in those situations, you want to do additional diagnostic testing to kind of confirm what's going on. So the immediate steps that we would recommend would be drawing blood for essentially an HIV viral load, HIV RNA testing ASAP. Now, you may or may not feel comfortable ordering this. Your lab may or may not be weirded out by you ordering this on a test on a patient who doesn't have confirmed HIV positive serology. You may need to quickly connect with an experienced HIV provider who does order that test all the time to kind of make arrangements to get it done. But I think increasingly our public health lab in Ontario recognizes that we sometimes need this test for this situation. But either way, if you're not comfortable managing HIV yourself, certainly make an immediate referral because there's a complicated decision that the HIV provider may need to make, which is whether they're going to discontinue the PrEP immediately and retest until they're absolutely confident of an HIV diagnosis, or whether they're going to say, I have enough information to conclude that this person is positive at this point, and I'm going to intensify their regimen right now. We don't have further time to talk about that decision making. It's a really challenging and interesting emerging conundrum that we're facing sometimes, but I'll leave it at that for now. What about monitoring for toxicity and tolerability? I've only included one slide on this because the good news is that it's not a huge issue for most people. So important to recognize that there are really not thought to be major drug-drug interactions for the most part. With PrEP, never say never. It's not unheard of, but it's extremely uncommon. Secondly, side effects are truly, truly minimal. So some people do have this kind of startup syndrome with a little bit of GI symptomatology in the first few days, maybe a couple of weeks that they start on PrEP. Some people don't, but even those who do typically find that it just goes away on its own. It's very seldom that someone would choose to stop PrEP altogether because of those symptoms, because they just go away. They're not mild. They're not severe. They tend to be mild, and certainly they don't outweigh the potential benefits in the vast majority of patients. There's rigorous analyses that have been done from all the clinical trials and published work showing that the risk of other adverse events is essentially the same as placebo. There are two famous organ toxicities that everyone likes to talk about with PrEP related to renal dysfunction and bone density, however, that are worth recognizing. They're both subclinical, meaning these are things that the patient is not going to recognize, and so it's our responsibility as the clinicians to be thinking about them. recognize that the renal issue is not that common, okay? It's actually quite rare. And if you do, the best way to kind of look for this is just to look at the creatinine quarterly. Okay, that's why that's one of the lab tests that we recommend every 3 months. We do recommend this kind of annual urinalysis, and on that you're looking for things like glucoseuria that would be seen in a non-diabetic. Proteinuria on a urinalysis may or may not be related to TDF toxicity, so you need to have a little bit of familiarity in order to really interpret that in detail if you're worried. But for the most part, if you just watch the creatinine, recognize that creatinines bounce a little bit around, but overall, if that line is flat, which most people it is, the person's fine. If you have any concerns, this is one reason to potentially refer to just help with interpreting these results, because you might be worried a bit of renal toxicity developing. Recognize that even in the event that it does occur, it tends to be reversible once you stop the drug. So it's kind of not an emergency in the vast majority of cases. Analogously with the bone story, we know that when people go on PrEP, TDF-FTC PrEP, their bone density goes down. But again, it seems to rebound when their drug is stopped. Fracture rates, which is the main reason we care about BMD clinically, are actually similar to placebo, but the big caveat there is, of course, fractures are things you wouldn't expect to see in the short time span that most of the clinical trials have gathered data from, like 1 or 2 years. It's something that you might see, many, many years later. So how do we deal with this? This is an area where there's not great certainty, not great data to guide us. We certainly don't recommend doing a DXA in everybody. We recommend simply following existing guidelines from osteoporosis literature around who needs a DEXA and who doesn't, because again, the impact of this in terms of the real thing that matters, fractures, so far there's not a clear signal, and it's a very long-term sort of issue. It's an area for further work, and certainly in someone who's at elevated risk of HIV now, because of what we know is happening, the risk is thought to be outweighed by the potential benefits. So the last thing that I want to emphasize is really, really, really important, and it's screening for STIs. Key points to remember, many, I would even say most STIs that we see, certainly most of the STIs that we see in our PrEP clinic, are asymptomatic. The patient is feeling fine, and they're surprised to hear that they have an STI. This is why we need to not just test when they have symptoms, we need to routinely screen. We need to do this aggressively, and we need to do it quarterly. So at every single visit, we actually will recommend, as per the guidelines, testing at all exposed anatomic sites. That's urethral testing, meaning a urine, rectal swabs if there's any receptive anal sex, pharyngeal swabs if there's any giving of oral sex. And when you're thinking about gonorrhea and chlamydia, the best way to get that urethral sample, the genital sample, is a first void urine. Remember that you want the first bit of urine that comes out, so we tell people to pee right into the cup in order to sample the urethra. It's different from a midstream urine, which we routinely use to diagnose UTIs, because those would sample the bladder. Here we want what's in the urethra. And many labs will chuck it in the garbage if you give them a sample that's got more than 20, sometimes they'll say 30 cc's, and then it's a whole bunch of wasted effort. So really important to give patients clear instructions about that. This test is a NAT test, meaning a highly sensitive PCR test, and it just gives you a yes or no, qualitative only, is gonorrhea and or chlamydia present in the sample. With the pharyngeal and rectal swabs, as you may know, here in Ontario, the Public Health Lab, thankfully about a year ago or so, moved to NAT testing also for those mucosal sites. And the nice thing about this is this culture system, this Aptima is the brand name of this culture system or swab system, is a single swab that you can collect from each of the pharynx and of the rectum, and in that single swab from each site, it'll give you a result for both gonorrhea and chlamydia on the same assay. So you're really doing one urine, one throat swab, one rectal swab in the HIRI-MSM who need this testing, and it's highly, highly sensitive and specific. If you happen to be in a setting where you don't have access to those swabs for some reason or another, then you could still go old school for culture. There are other arguments that to say that we should be doing more cultures, actually, especially for gonorrhea, because this is the only way that we're going to get culture and sensitivity data. But remember that if you're going to do this sort of bacterial swab for gonorrhea culture, you need to write that you're looking for gonorrhea. Otherwise, your throat swab will come back saying something like no group A strep identified, and they haven't even plated on the right media to look for gonorrhea. So really important to remember that when you're using the swab system. Also important to remember that when you're testing for chlamydia by culture rather than by NAT, you need to use these viral swab kits. Okay, chlamydia is not a virus; it's a intracellular bacterium, but nevertheless, we use these viral culture media, these little vials that have the pink liquid with the special sticks. Many people will recognize this from flu season. We use these culture systems for NP swabs to rule out influenza. Same idea, also used for herpes. Again, write chlamydia culture on the requisition. Again, this is your backup if you don't have access to the NAT test because it's not as sensitive, it's not as specific, but certainly is justifiable if this is all you've got, and certainly a nice idea if you're worried about actual infection, especially on the gonorrhea side, because you also get that culture and sensitivity data, but not absolutely essential perhaps. Same deal with the rectal swab again, that you could use these culture systems as well. We like to also point out that the patient can potentially collect their own rectal swab, and some people are collecting their own throat swab without gagging, and we just kind of give them these simple instructions. I won't talk through them in detail in the interest of time, but that's also possible. The last thing to remember to do in terms of STI testing is your syphilis serology. So many people get confused by syphilis serology. Don't have time to talk about that in detail, but there's other resources that can help you interpret the results that you get because it's a little tricky sometimes. Again, common cause for referrals, but look into the Canadian guidelines and the resources listed here. Management I'm not going to talk about for the STIs, but this is something I just want to flag. Recognize that providing PrEP does mean that you're going to be in the business of providing STI treatment. That requires not just the treatment, but also the contact tracing and counseling. There's great guidelines, once again, that we have that are freely available online for how to manage that. There's clear recommended frontline regimens. The drugs are provided by public health, and you need to stock that probably if you're going to be seeing a high volume of PrEP patients. So the counseling is the last non-lab piece. Just want to emphasize again the adherence pieces we talked about earlier. Pill boxes and encouraging people to link PrEP to an existing routine, a smartphone alarm, keeping pills in different locations if they tend to move around a lot between different places. And then talking about other risk reduction strategies, reassessing the need for PrEP, so always remembering condom use, providing it, talking to partners around sexual health, encouraging people to ask their partners when the last time was that they were tested and treated. Thinking about some of the other coexisting conditions that travel together with sexual risk, so recreational alcohol and drug use, and other mental health issues that are so common in many of the folks that we see. So this is just the overview again. Key points, provide it for 3 months at a time with no refills. Make sure you've documented HIV seronegativity each time. Side effects are rare. Renal toxicities do occur, but they're uncommon, and overall AEs are at the same rate as placebo. Really important to screen regularly for STIs, and then do that counseling piece and reassess the indication at each visit as well. I think this is the last slide. It's just a slide of practical tips before taking some comments that I see are rolling in. To be realistic, if you have your patient do the lab test 1 or 2 weeks before the visit, then of course you're going to have that HIV test in front of you at the time that they're there. So just like most other things, just remember to give them the requisitions in advance of the next visit. Otherwise, you waste the visit, of course, just like any other area. And you can also manage the STIs that have come up in the meantime because they're there in the clinic with you. Remember to think about adherence, seroconversion, and STI symptoms, and is PrEP still indicated? Again, in the people who have been on PrEP for a while, they're kind of used to the flow. Our conversations are super brief. They touch on these key issues. If all's good, it can be over in just a few minutes when you get accustomed to providing. And frankly, that's really important to be doing because we're in an era where we need to be scaling up PrEP. And once you're comfortable that the patient's got all the information, they've been counseled extensively, it's really these things that you're checking in on each time. And then finally, drug coverage is a really important issue. TDF FTC PrEP is covered under the Ontario Drug Benefit Program. It's also covered under FNIB and under the Interim Federal Health Program for refugee claimants and refugees. Recognize that with ODB, it's a little bit tricky. I call it partial coverage because, as you know, you have access to ODB if you're over 65, on Ontario Works or ODSP. But otherwise, you have to buy into it. For Trillium, the Ford government has just made the changes to OHIP Plus, so you have access to ODB if you're under 25 but have zero private coverage. So it's a bit of a hodgepodge, but certainly one of the other things we do in the PrEP clinic is help people navigate the drug coverage issues. I'm sorry that wasn't my last slide. I forgot that there's this reminder to fill out the HIV requisition in full. This is the new requisition. There's a box here that we encourage people to check off if they're doing HIV testing in the context of PrEP, so we can use that as a way to check to quantify PrEP use in the province. And also just remember that you need to have supplies in order to do the proper STI testing in your clinical practice setting in order to actually do the guideline recommended work. So here are some other resources. I'm not going to talk through them in detail, the guideline. This is a module that we created on which my slides today were largely based. Katie and the OHTN have portals that are either existing now or coming soon. I encourage you to look at those. Oh, and here's my shameless plug. I'm going to be cycling to Montreal from Toronto this summer. It's the third or fourth time I'm going to be doing it in my life. I haven't done it in a long time, to raise funds for the Toronto People with AIDS Foundation, an amazing organization in our midst. If you have a soft spot for PWA and are interested in supporting me, I would love your support, your sponsorship, but you don't have to. This is an email address that you can reach me at if you don't have time to get into your questions today, but I think we have a little bit of time right now before we wrap up. So thank you so much, and I'll pass it back to Kyle and Andrea.
Thank you so much, Dr. Tan. That was fascinating. I think we have a couple of questions. The first one is, can the guidelines from the previous slide, so I guess when you had kind of posted the summary of the guidelines, be applied to clinical decision-making regarding PEP for occupational exposures, i.e. what is considered a high versus low versus negligible risk exposure?
Yeah, great question. So I'll answer the question by saying yes and no. Yes, in terms of, undetectable equals untransmittable. That is absolutely the case. But not quite in terms of, that detailed list that I provided earlier. Those things like having syphilis, having a rectal bacterial STI, using PEP over and over, et cetera, those things are used to really quantify kind of what you might classify as a chronic risk, or a longer-term ongoing level of risk, which is really the relevant type of risk to think about in the setting of whether you're going to start someone on PrEP or not. In the setting of post-exposure prophylaxis, it's really a decision that you need to make in relation to a very specific incident. Someone's going to tell you, this happened to me 2 days ago at 10:30 p.m., and you need to understand what happened in that moment to assess the indication for PEP. I'll point out that in the guideline that I alluded to a few times in the slides, that guideline actually talks about both PrEP and NPEP in the same document. We recognize that people are often kind of thinking about these things in many of the same ways. It's a different clinical scenario. The recommendations are different as a result, but I recommend that you take a closer look at that, and we didn't quite have time to go into the details of assessing an individual exposure for PEP, but the underlying thing that is in common is undetectable equals untransmittable.
Awesome, thank you. The next question is, are you able to comment on the efficacy of on-demand PrEP? Is it comparable to daily PrEP? And who would you recommend on-demand PrEP to compared to daily use? Great question.
So this comes up a lot as well because it's a bit confusing because there's only the single clinical trial, it's called the EPERGAY trial, that was ever that's ever been published and shown on-demand PrEP to work. Important to emphasize once again, that was done only in GB-MSM, so we have no data to support on-demand PrEP use in other populations, such as people whose exposure risk would be through heterosexual activity or injection drug use. So the efficacy from that one clinical trial was comparably high. The point estimate was 86% reduction in risk, and the only reason it wasn't higher was that there were 2 infections in the arm that was assigned to using PrEP, and those 2 infections occurred in people who told the study team that they were not using their PrEP at the time that they acquired infection. So again, it's related to non-adherence primarily, as opposed to the drug simply not working in this way. That being said, it's a much smaller body of evidence, which gives some people pause. Some people included the guideline panel that put together the guidelines in which we do talk about on-demand PrEP as an option. It is listed as a consider. So the quality of evidence is high, but rather than that level 1 recommendation, it's a level 2 recommendation. The other caveat that the guidelines go into in a lot of detail around this are that in that particular clinical trial, there's a relatively small number of people who were using the on-demand regimen infrequently. In other words, most people were having a sexual partner at least once a week or so. And as a result, we don't have that much data on people who anticipate using on-demand PrEP, maybe once a month or less frequently than that. The data that we do have suggests it works, but again, the total volume of data is smaller, and hence that gives some people pause. Personally, as a result, I might be being a bit conservative in this regard. When someone tells me, I think I'm going to be using PrEP once a month or less than that, I hesitate personally to recommend on-demand PrEP because there's a little bit less certainty. I don't think it's wrong to do it, but I think if they're totally willing to use either approach, then, I do tend to favor the daily. I recognize that that's a little bit counterintuitive because maybe they're trying to use the on-demand because they want to take fewer pills, just once a month. But we're in this kind of catch-22 with, just the volume of data that we have. The data that we have is compelling and it's high quality, but it's just not, large in amount. So when would you actually recommend it? Certainly in someone who is going to be, maybe having exposure, 2-3 times a month. That means, okay, that's a reasonable option. If they're for some reason opposed to using the medications more consistently, the people who designed the IPRIGATE trial said that their motivation for doing so was that they thought it would help some people with medication adherence, and they thought that it would help people in terms of side effects, less drug, less side effects. If you actually look at the data, ironically, I would argue that neither of those things have been borne out in the data. The adherence was not better, in my opinion. It was actually still kind of challenging for many people to take the medications. I'll point out that the on-demand regimen is a little bit complicated. I'll tell you what that is in just a second. And then side effects were not appreciably different in the two arms of that trial at least. So, the last setting is in settings where it's not fully reimbursed, sometimes there's a clear cost advantage because you're literally using less product, so that's going to cost you less. So that's one clear advantage in some settings. The regimen itself, the last thing I'll say, it's a little complicated. So on demand, if someone's anticipating sex, tonight, they've got a hot date, it's Wednesday night, off they go, the recommended regimen is 2 pills together within 2 to 24 hours before the sex. So that could be, today during the daytime, it could have even been last night, 2 to 24 hours before the exposure, followed by 2 daily doses. So that means 1 pill on Thursday, 1 pill on Friday, and then this Wednesday night exposure is covered. Now, if they go on to have an additional exposure, let's say on Friday night, what they do is they continue taking 1 pill a day until, again, 2 days have elapsed since the last sex. So sex on Wednesday plus sex on Friday means 2 pills beforehand on Wednesday, 1 pill on Thursday, 1 pill on Friday, 1 pill on Saturday, 1 pill on Sunday, then you're done until the next exposure. So you can see how it's a little bit complicated, but for some people it works.
Okay, and I think the last question we have is, are there any medications you recommend a patient avoiding while on PrEP, or certain recreational drugs or alcohol consumption to avoid?
Great. So the short answer is, fortunately, not really, okay? If someone's on a really, really rare drug, I'll probably look it up, okay? But, I mean, I can tell you I've not yet encountered a single person who's on a drug that's got a known drug-drug interaction that's going to inhibit my ability to put them on PrEP. And so, it pretty much doesn't have drug-drug interactions, pretty much, okay? One that is getting a little bit of special attention recently, okay, only because we're explicitly paying attention to it, is people are starting to ask very, very good questions around PrEP in populations other than HIRI-MSM, such as transgender women. And so one very important question has come up: what's the interaction with hormones? And initially we said what I said, which, no interaction. people who have gone on to do very careful PK studies, literally in the last year or so, have started to show maybe there is a little bit of an interaction in the direction of slightly lower hormone levels. Okay, but the clinical relevance of this is still not clear. It's an active area of research. Is it enough to say don't take your PrEP or don't take your hormones? Certainly not. But it's an area of active research. And again, it goes to show, even in this setting, you know, it's not enough to tell us to change our clinical practice in any way. So you can be assured that that's okay. Recreational drugs or alcohol consumption, there's no specific interaction either. Just the, you know, the motherhood statements that we would make about use of substances in moderation.
I think that's it as far as questions, unless anyone wants to add anything in. I think I'll turn it over to Kyle to wrap up then, but thank you so much, Dr. Tan. That was a really great talk. I'm very excited to have gotten to listen.
Fantastic. Well, thank you so much for the opportunity to present. I really appreciate it, and hope you all feel prepared to go out there and be part of this movement to kind of scale up PrEP delivery, because it's certainly needed.
Great. Thanks so much, Dr. Tan. And I'm just going to echo actually exactly what Andrea said and mentioned before, that this was a fantastic presentation. I'm not sure if you're aware of RNAO's best practice guidelines, BPGs, but we do actually use the GRADE methodology. So many of our listeners will actually be familiar with that framework. I know that you had mentioned that you had used the GRADE framework for your guidelines. So that was great to hear. A couple of notes for our participants. I did want to thank you for joining the session this evening. A reminder that this is recorded and it will be posted to the interest group website within the next 3 to 4 business days. We did just want to flag that we are going to be taking a break for summer for the NPIG Insider Series, just doing some planning sessions over the summer, but we will commence again in September. Feel free to reach out to us if you have any questions, potentially ideas or topics for the summer and subsequent months. With that, I'll conclude our webinar for today, and I'm going to wish everyone a wonderful evening. Thank you so much. Bye-bye.
Thank you.
Thank you.